Next we have Dr. Kishara Gooneratne, who is the Honorary Secretary of the College of Physicians, as well as he is a consultant neurologist attached to the Provincial General Hospital Hambantota, and he will be talking on headaches from a neurological point of view. Over to you, Dr. Kishara.
Thank you very much, Shehan, for that introduction, and I'll start by thanking the CCP for giving me this opportunity to talk to you all. And let's move on. Right, so headache is the most frequent referral for neurologic consultation in our patient setting, and that is so worldwide. And I think there's this trepidation that occurs when a pregnant mother does come with a headache, and it's a headache to treat that patient's headache, in other words. And that is because, as you know, that there are what we call primary headaches as well as secondary headaches. Primary headache is where there is no medical condition. The headache is not as a result of a primary medical condition, whereas secondary headache is a condition that is secondary to a medical condition. So there is a propensity for a pregnant mother to actually have devastating secondary headaches. And as physicians, I suppose the first step in evaluating these kind of patients is to actually risk stratify the possibility of a secondary headache occurring in that particular patient. And why is that? That is because these patients they have multiple risk factors to develop secondary headaches. For example, as my previous colleagues who has spoken to you before have highlighted, pregnancy is a hypercoagulable state. There are hormonal changes where there's increase in estrogen and progesterone, and the estrogen progesterone ratio increases over time during pregnancy, as well as these patients are more likely to undergo anesthesia during labor. So these are some of those multiple risk factors that could increase the incidence of secondary headaches during pregnancy. So if a patient comes to you with a headache, there are three possible scenarios you would encounter. Should either have a primary headache diagnosed prior to the pregnancy and now coming with a usual headache. That's the first scenario. The second scenario is if it is a patient who has a primary headache and she presents, she does not have a primary headache but presents to you with the first severe headache during pregnancy. And the third scenario is patient has a primary headache but now is coming with a different type of headache. Okay, so these are the three possible scenarios that you would generally encounter in a patient who's pregnant and who's got a headache. And the last two scenarios is where you'd be considering the possibility of an underlying disease or a possibility of a secondary headache disorder. Okay, so when would you suspect a secondary cause? So these are the red flags that you would generally consider. The first one is if it's sudden in onset. A thunderclap headache is always, whether you're pregnant or non-pregnant, is almost always a red flag sign that you need to consider the possibility of secondary headache. If the headache is progressive in nature, if the headache changes, the quality of or the character of the headache changes throughout time. If the headache is refractory to treatment, if it worsens during Valsalva, straining, coughing, or sneezing, or if it worsens with posture. These are all red clinical signs to suggest that we are dealing with a probable secondary cause. On examination, papilledema, peripheral edema, hypertension, focal neurological signs, fever, as well as seizure are all physical signs that you would look for when you would suspect a secondary cause for headache. So these are the common secondary headaches. As you can see, this is an exhaustive list, right? What I want to highlight in this list is that most of the causes or secondary causes for headaches during pregnancy are often due to some sort of vasculopathy. For example, reversible vasoconstriction syndrome, posterior reversible encephalopathy syndrome, um, even cerebral venous thrombosis, all of which are either vasculopathy or as a result of dysfunction in coagulation. Okay, so from this point onwards, it will be case histories. I hope you'll be able to respond to the multiple choice questions that are posed. Okay, so let's start with the first case history. This is a 34-year-old pregnant mother, P1C0, or the first pregnancy. In her first trimester, complains that she started to experience severe throbbing headaches on the right side of her forehead and above the ear. Soon after the headache begins, she finds that she becomes nauseous. Right? When questioned further, the patient goes on to describe how the sunlight from her large window and staring at her screen makes the headache much worse, and sometimes even causes some ringing in her ears. In addition, the patient believes the glare on her computer may be the cause of her headache, because she starts to see bright spots on the screen prior to the onset of the headache. Normally, after sleeping an hour or two, the pain subsides. She says she had such headaches in the past prior to her pregnancy. Okay, so what is your diagnosis? Number 1, tension type headache, migraine with aura, migraine without aura, CVT, or what we call cerebral venous thrombosis, or meningioma. So there's a poll, so you can answer. Right, so most of you have got migraine with aura, and yeah, so that's absolutely right. Okay, so move on. Okay, so migraine in pregnancy is the commonest type of headache that you would encounter. You should understand that. So the two types of migraines. I'm not going to go into the clinical characteristics of what migraine is, but this is migraine with aura. What I wanted to highlight is there on this slide. So migraine is the commonest. It's about its incidence is around 50 to 60% of all headaches that you would encounter. And what you should know is migraine without aura, which is the commonest type of migraine, actually improves during pregnancy. And improvement or remission is observed in nearly 50% of patients during the first trimester, nearly 80% or a little over 80% in the second trimester, and nearly 90% during the third trimester. The concept is that estrogen is protective towards migraine. So as the pregnancy progresses with the estrogen concentrations in serum, the migraine with aura basically improves. However, migraine with aura is less likely to improve, which is the case in this particular patient. New onset migraine with aura and even without aura may occur in the later stages of pregnancy. Okay. Right. Okay. So these are the clinical features or the diagnostic criteria that you would encounter. Which you would consider in making a diagnosis of migraine with aura. So you can see the criteria. And why is it more prominent in pregnancy? So there are a few theories that are going around with regards to its pathogenesis. There's apparently an increased endothelial reactivity during pregnancy, which might explain the fact that there is an increase. There is this persistence of migraine with aura. Or the other possibility is that the high estrogen to progesterone ratio may lower the threshold for cortical spreading depression, which is the cause for the aura that you would experience, that these patients would experience during pregnancy. Okay, so the second question: what's the treatment option you would choose for these patients? Number 1, treatment with acetaminophen, that is paracetamol and metoclopramide. Initiate prophylaxis. Whatever type of prophylaxis that's available, start them on a non-steroidal anti-inflammatory drug, or you can use whether to use injectable therapies such as botulinum, peripheral nerve blocks, trigger point injections, and sphenopalatine ganglion blocks. Okay, let's see what most of you all have answered. Yeah, so most of you all have, 66% of you all have actually answered with the first option, which is correct. Unfortunately, not many of, only 2% have actually considered injectables. Well, I would suggest either one or four. The other two probably are not indicated. Let's discuss this a little bit further. So the safest acute treatments in pregnancy is paracetamol or acetaminophen with metoclopramide. They can be both given enterally or parenterally. Opiates not indicated during pregnancy. Non-steroidal anti-inflammatory drugs or NSAIDs can be used. However, they can be used during the second trimester for a short period of time. The first trimester generally causes an increased risk of miscarriages, and during the third trimester it causes premature closure of patent ductus arteriosus, which is not what we want. So there is a place of non-steroidal anti-inflammatory drugs if the patient really requires it. However, that would be during the second trimester. Could we use triptans? So there is this growing evidence that triptans are increasingly found to be safe during pregnancy. Number of cohort studies have found that the malformation risk, the risk of prematurity, spontaneous abortions in a migraine population, where they've a dichotomous cohort where the migraineurs were divided into patients who are on triptans and who are not on triptans. They found that there was no increased risk of any of those risk factors, for example, malformation rates, prematurity, as well as spontaneous abortions. However, compared to a healthy group where the control was compared with a non-migrainous population, there was this increased risk of spontaneous abortions. However, if we actually took away the risk factor of triptans and just compared migraine, the population with migraine as well as the population which did not have migraine, there was a increased risk of spontaneous abortion. So there is this growing evidence that triptans may be actually safe to use during pregnancy. Okay, so moving on. So actually interventional therapies and non-invasive neurostimulation devices are actually indicated during treatment of pregnancy, and they are quite safe. So in that particular scenario, if you actually suggested treatments such as Botox, peripheral nerve blocks such as occipital nerve blocks, great occipital nerve block, as well as the supraorbital nerve blocks, they're all safe in pregnancy. If you're finding it difficult to treat these migraines with paracetamol and metoclopramide, I suppose the next option would be an injectable option, which is done in this country. The others are, of course, neuromodulation devices, not so much available in this country. The transcutaneous supraorbital nerve stimulator, TMS or transcranial magnetic stimulation, as well as non-invasive vagal VNS or vagal nerve stimulation, all of which are indicated for both treatment as well as prophylaxis in migraine, especially during pregnancy. So there are instances where we may need to consider prophylaxis. However, in the majority, prophylaxis is not indicated because most of the patients that have migraine are the patients without aura, and they actually improve during pregnancy, and you can actually counsel your patients that their migraines are going to improve. However, if you really need to start them on prophylaxis, propranolol would be your first first choice in preventive medication. Your second line would be amitriptyline as well as verapamil. These are all category B drugs. Okay, magnesium supplementation, again used in non-pregnant patients for prophylaxis, can also be used in pregnancy as well. Right. Okay. Non-pharmacological treatment methods are emphasized during pregnancy. You need to identify triggers and such as diet and sleep disturbances, and counsel accordingly. And there is evidence to suggest that biofeedback methods, relaxation techniques, cognitive behavioral therapy, all of which have a effect on the treatment of migraine. Okay, so we'll continue. So the same mother is now in her third trimester with a period of amenorrhea of 34. She complains of a holocephalic headache with nausea and vomiting. The headache is unlike the one she normally experiences, so she comes under the third category in our clinical scenarios, which I presented to you before. And she complains of difficulty recognizing objects with her within her visual field. Headache is unremitting. What is the diagnosis? Is it number 1, migraine with aura, CVT, press or posterior reversible encephalopathy syndrome, subarachnoid hemorrhage, and arterial dissection? Alright, so most of you all have actually got that correct. So it's posterior reversible encephalopathy syndrome, which was actually discussed in the morning. And what would you do next? Perform a PET screen, urgent imaging, start anticoagulation, start acetaminophen and metoclopramide, reassure the patient. Okay, moving on very quickly. So most of the responders have actually suggested urgent imaging. I would agree. However, I think I would do the PET screen first, because that has the if you're suspecting posterior reversible encephalopathy syndrome, yes, the confirmation is through radiology. So it's a neuroradiological clinical entity, which is characterized by, again, insidious onset of headache, impaired consciousness, visual changes, or blindness, seizures, nausea, vomiting, and focal neurological signs. And 2/3 of patients with press headache is the most commonest presentation, which is generally occipital and bilateral, and they generally develop within 12 to 48 hours. And it's very difficult to differentiate between a migraine with migraine with aura, and it's associated commonly with eclampsia, pre-eclampsia and eclampsia during pregnancy. However, it can be associated with all the other causes that cause disruption in autoregulation, as was discussed in the morning in our first talk. Okay, so and these are the general changes that you would generally see. I think that was dealt with in the morning. Right, okay, so the history continues. The patient has had an emergent section following the diagnosis of preeclampsia. She complained of 3 consecutive episodes of spontaneous severe thunderclap headache arising from the back of the neck and nausea. On the 7th day of postpartum, the maximum intensity of the pain was within 1 minute of onset, and headaches lasted for less than 2 hours each time. Her MRI is as follows. So to make things easier, there are these multiple constrictions that you see on the MR angiography. What's your diagnosis? Migraine, reversible cerebral vasoconstriction syndrome, press, CVT, or subarachnoid hemorrhage. So we poll the answers, and most of you have answered correctly with RCVS. This is the typical history that you would generally get with a headache that presents as RCVS, where there will be typically a thunderclap headache, very typical, very similar to subarachnoid hemorrhage. However, and it's precipitated by sexual activity, valsalva maneuvers, and emotion. Often seen in the postpartum period, usually after delivery, a week after delivery, and that the clinical scenario that was presented was actually of a actual patient that presented to us some time ago. And the treatment is to reassure the patient, start them on a vasodilator, which is generally a calcium channel blocker. However, and nimotidine is the drug of choice, as is in subarachnoid hemorrhage. Of course, the evidence to basically support the use of calcium channel blockers is generally based on observation studies, right? Okay, so the last few questions. The patient underwent an LP and the CSF found to be normal. A day later, she was complaining of severe holocephalic headache, which was worse on erect posture and better while lying down. She's also complaining of nausea and tinnitus. What is your diagnosis? Intracranial hypertension, intracranial hypertension, migraine, CVT, or subarachnoid hemorrhage. So we poll the answers. All right, okay, and most of y'all have got it correct. It's an intracranial hypertension as a result of dural leakage. So this is one of the headaches that you need to be looking out for, because most of these patients undergo epidural during labor, and post lumbar puncture headache is a headache which is worse when the patient is erect, and better when the patient lies down. That is the opposite of intracranial hypertension. So this the differential diagnosis of secondary headaches during the postpartum period is many, and there is a high risk of postpartum eclampsia, subdural hematoma, especially during delivery, angiopathy, cerebral CVT, as well as pituitary tumor apoplexy, all differential diagnosis that one would have to entertain during the postpartum period. These are the important secondary headaches that I have not discussed during our previous slides. Pituitary tumors, they because of the vascularity and then the effect of the estrogen and progesterone, there is a chance of pituitary tumors, which are microadenomas, to enlarge in size, and also there can be a risk of apoplexy as well. Then cerebral venous thrombosis, as you know, is highest during third trimester as well as postpartum period, and there is also this slight increased risk of idiopathic intracranial hypertension, especially in obese mothers. All right, so those are the secondary headaches that we should be on the lookout for. So in conclusion, migraine is the most common cause of headache during pregnancy. Non-pharmacological treatments of migraine are emphasized during pregnancy. There is this growing evidence to support the use of triptans in migraine, and you need to consider important causes of secondary headache, which includes vascular disorders, mainly preeclampsia, reversible vasoconstriction syndrome, CVT, as well as idiopathic intracranial hypertension. Right, so I think that's all I have to say. I'll be happy to answer any questions if we have time.
Thank you so much, Dr. Kishara, for that presentation, and thank you for turning the tables the other way around with imposing questions on the audience and keeping them lively. I hope. There is a question. What are the indications for migraine prophylaxis in pregnancy?
So I think it's there isn't a difference in the indications for migraine prophylaxis if you're non-pregnant as well. So for example, the guidelines suggest that you need to have 4 or more episodes of migraine for you to start on prophylaxis. However, I think the threshold to start prophylaxis should be far higher because of the risk of major congenital malformations associated with prophylaxis, and you need to basically counsel the patient that your migraines are most likely going to improve during the pregnancy. However, if the migraines are affecting the quality of life in those particular patients, yes, I would advocate starting these patients on prophylaxis on a lower dose of prophylaxis. For example, propranolol, we would not go for say 120 milligrams to 300. So the range we would generally use in a non-pregnant patient would be around 120 to 320 milligrams of propranolol. We would generally use the doses that are that most people in this country use for non-pregnant patients, which are subnormal doses, which is around 20 milligram BED or 40 milligram BED for a patient who's got migraine, which is generally used in this country, which is suboptimal in non-pregnant patients.
There's a physician who is, I think, treating patients with related to pregnancies, asking a question, flunarizine, is it contraindicated in pregnancy?
Yes.
And then there is another question. what is the blood pressure threshold where peak press is concerned to consider pregnancy in hypertension, pregnancy-induced hypertension? Blood pressure threshold to consider press.
I'm not aware of a blood pressure threshold. It's actually not the height of the blood pressure that actually causes the press. It's actually the blood pressure fluctuations. It's the troughs and the the highs and the lows that actually causes the vasogenic edema. And treatment is basically you need to treat the cause. So in most cases it's preeclampsia and eclampsia.
Thank you so much.